Saraka, have you started the meeting? Hi, Saraka, have you started the meeting?
Hi, sir. I think you can start the meeting on the other side as well.
I think there's 37 participants so far. Right.
Sorry, Olanike, have you been able to contact Dr. Dike?
Yes, Prof. I did.
Okay.
Okay, so he was actually just leaving work. He said he would get into his car and join.
Okay. All right.
Yes, thank you.
Oh, so how is the flow going? The flow going to be? We start with Mr. Arvind.
Hi, Prof. Yes, and then I'll introduce you.
Okay, then you introduce me, then I
take it over from there.
All right.
Right.
Okay.
Thanks, Prof.
Yeah.
Good evening to everyone on the line. We'll be starting in about 2 minutes. Thank you. We may commence. So good evening to everyone, and thank you for joining us tonight. My name is Arvind Hariram, and I'm the medical manager with AstraZeneca Pharmaceuticals, responsible for the cardiovascular, renal, and metabolism portfolio. And it is my pleasure to officially welcome you to this Diabetes and Ramadan program that will be carried out across the entire sub-Saharan African region. Thank you to our distinguished faculty for accepting the invitation to speak today. And I must say a lot of time and effort has gone into the preparation for the content that they will be delivering for you this evening. This meeting will focus around the management of diabetes and chronic and Ramadan, which is a very auspicious part or period where disease management differs from the rest of the year. And the session will include very practical information on managing your patients during this important period, especially patients with other comorbidities. But before I hand over to our chair for this evening, I would like to say a few words on behalf of AstraZeneca. And I'm sure that you're all well familiar with AstraZeneca as a global science-led biopharmaceutical company. And in the Middle East and Africa region, we have more than 2,300 employees based in 33 different countries across our region. Our African cluster is made up of South Africa, Sub-Saharan Africa, as well as French-speaking Africa. And our main aim is to transform the lives of patients by ensuring improved access to our innovative medicines, partnering with governments, societies, and healthcare stakeholders in Sub-Saharan Africa to help shape the future of healthcare. So when we look at our portfolios that we're involved in, that includes oncology, respiratory and immunology, rare diseases, as well as cardiovascular, renal, and metabolism. From a cardiovascular, renal, metabolism portfolio, we know that these diseases often coexist, and many patients have symptoms or underlying pathologies associated with more than one CVRM disease. And if you look at it, we know that the burden that we are dealing with, especially that cardiovascular disease is the #1 cause of death globally. More than 65 million patients are living with heart failure, and 1 in 3 adults living with hypertension. We're also exploring into a new area with NASH, which we know is the fastest growing cause of chronic liver disease. Our ambition is to fundamentally transform the care for millions of people who are living with the complexities of cardiovascular, renal, and metabolism. And in this regard, we are focused on 4 key areas, that being from a cardiovascular disease risk and slow disease progression, from a heart failure perspective, to eliminate heart failure as the first cause of hospitalization, from a kidney disease perspective, to eliminate the progression to kidney failure, and finally, from metabolism and liver diseases, to eliminate NASH as a leading cause of liver failure. However, our commitment remains strong. We are committed to scientific leadership. We are committed to continuous education programs like tonight, and wish to bring other forums to you as well. We are investing in R&D, and we are focusing our efforts on the commonalities between these diseases and the underlying mechanisms to better understand how our portfolio might be used to address multiple risk factors and other comorbidities, and whether combination therapies of medicines might offer unique patient benefits. We are advancing science through global comprehensive programs like our DAPA program, which you're well familiar with, which was investigating dapagliflozin under various different clinical conditions, and enhancing, more importantly, the standard of care to improve patient outcomes. So with that, thank you very much. And it is now my honor to introduce to you the chairperson for today, who is Professor Ibrahim Gizawa. Professor Gizawa works as a professor of medicine at the Bayero University, Kano, and is an honorary consultant physician and endocrinologist at the Aminu Kano Teaching Hospital. He's a member of many professional associations, including the Endocrinology and Metabolism Society of Nigeria. Dr. Ibrahim is a passionate teacher, researcher, and mentor. Over the past decade, he has been educating HCPs and guiding persons living with diabetes on how to observe Ramadan fast safely. His research interests include the impact of obesity on cardiometabolic diseases, diabetes and Ramadan fast, and diabetic foot ulcers. He's a deputy editor of the Nigerian Endocrine Practice, and he has several publications in peer-reviewed local and international journals. He's currently the chair of the Nigerian group of the Darul Africa. So without any further ado, I'll now pass it on to Professor Gizawa. Thank you so much, Prof. And over to you.
Thank you very much, Mr. Andin. Good evening, our eminent speakers and the audience. So today, my task is to first of all give a brief overview of what we are going to be listening to, the topics that the speakers are going to be discussing. And then I will introduce the eminent speakers. And then after that, lay down some housekeeping rules. And then only after that, we'll now give the speakers chance to speak. Now, we all know that diabetes is one of the major metabolic diseases, and the prevalence is increasing rapidly globally. And we have quite a number of Muslim countries that constitute one of the first 10 countries with the highest population of patients living with diabetes, and then, of course, wishing to fast during this month of Ramadan. And even though Ramadan is obligatory upon all healthy, mature, sane, and resident Muslims, we do know that the ill, the old and frail, travelers, menstruating, pregnant, and nursing mothers are exempted. Patients with diabetes fall into the category of those exempted, but nevertheless, many of them insist on fasting. So this poses a challenge to healthcare providers in the management of such patients. And considering the risk associated with fasting in such patients that have not been evaluated prior to Ramadan. So, so this stratification, which Professor Ahmed Reja is going to talk about, is extremely important while evaluating our patients and preparing them, to fast during Ramadan safely. And apart from that, of course, you also have the issue of educating the patients on how to conduct themselves during Ramadan, including a discussion on nutrition, on exercise, on when to break the fast, on self-monitoring of blood glucose, and importantly, for us as healthcare providers, is the issue of adjustment of medication, whether oral or injectables. And Dr. Charlotte from Ghana will speak on the topic in greater detail. Another major challenge in managing this patient is when one is confronted with a patient with diabetes and related comorbidities or complications who insist on fasting. So for that, Dr. Hussein and Dr. DK will outline the special considerations in relation to patients with diabetic kidney disease and cardiovascular disease, respectively. So at the end of this well-packaged webinar, you will be equipped with the requisite knowledge required to evaluate, advise, and manage your patients with diabetes to enable them fast safely during Ramadan. So without much ado, I will now go to the next step, which is to introduce our eminent speakers. So let me try to share my screen so that we will all follow the profile of our speakers. I will start with Dr. Ahmed Reja from Ethiopia. Dr. Ahmed Reja was trained in general medicine at Minsk Medical Institute, Belarus, now Minsk Medical University. It's also my former medical school, but Professor Ahmed Reja, of course, graduated so many years before I did. So he trained at Minsk Medical Institute in Internal Medicine at the Department of Internal Medicine, Faculty of Medicine, Addis Ababa University. He then went to Royal Hallamshire Hospital, Sheffield University, Sheffield, UK, for his fellowship training on diabetes and endocrinology, where he spent 2 years as a clinical research fellow and trained under Professor J.D. Ward. He also holds a postgraduate diploma in endocrinology from the University of South Wales, UK. Dr. Ahmed Reja is currently working as a consultant medical specialist in internal medicine, diabetes, and endocrinology. He is also an associate professor of medicine, Department of Internal Medicine, College of Health Sciences, Addis Ababa University, and has served for 4 years as the vice president and chief executive director of the College of Health Sciences of the same university. He has also served as head of the endocrine unit of the Department of Internal Medicine and head of the Department of Internal Medicine, Faculty of Medicine, Addis Ababa University. He has published at national and international journals on various aspects of diabetes in Ethiopia. Besides attending international diabetes courses and workshops, he has presented several research and review papers on various aspects of diabetes at international and local fora, such as Diabetes UK, World Diabetes Congress, IDF Africa Region, Ethiopian Medical Association annual meetings, Ethiopian Public Health Association annual meetings, and Kenya Diabetes Study Group. In his capacity as president, of the Ethiopian Diabetes Association, Dr. Ahmed was instrumental in securing 2 big grants from the World Diabetes Foundation: the early detection and treatment of diabetic retinopathy in 5 major university hospitals, and diabetes outpatient services in 12 hospitals of the major regions of Ethiopia, and the Changing Diabetes in Children program, which focuses on improving the care of now over 15,000 Ethiopian children and adolescents with type 1 diabetes by providing free insulin testing strips, education to patients, family, and healthcare professionals, and Life for a Child program, which also provides free insulin, syringes, and monitoring devices for over 5,000 Ethiopian children living with type 1 diabetes. Currently, he is leading the Non-Communicable Diseases Alliance of Ethiopia as its chairman. He is actively working as an advocate of NCDs in Ethiopia by giving press conferences, interviews on different media, delivering education on prevention and control of NCDs to various stakeholders. He was recently elected as president of the Society for Endocrinology and Metabolism of Ethiopia, which is registered as civil society organization and working to improve endocrine care in Ethiopia. He is also a member of Diabetes and Ramadan Africa region. So let's welcome Associate Professor Ahmed Reja from Ethiopia. Next is Dr. Charlotte Ampong from Ghana. Dr. Charlotte Ampong is an endocrinologist and a senior physician specialist. She is a fellow of the West African College of Physicians and holds membership certificate with both the Ghana College of Physicians and the West Africa College of Physicians. She also has a postgraduate diploma in endocrinology with the University of South Wales, UK. She is committed to improving diabetes care and has close to 2 decades experience in the field of medicine. So, Dr. Charlotte, you are welcome. The next is Dr. Hussein Baga from Kenya. Dr. Hussein is a consultant physician and nephrologist working at the MP Shah Hospital. He is the head of the renal and transplant unit and also the head of the Department of Internal Medicine. Dr. Baga did his Masters of Internal Medicine training at the Aga Khan University and his nephrology training at the University of Witwatersrand in South Africa. He has also completed his MRCP in nephrology. Dr. Baga is a member of the Royal College of Physicians UK, member of the Royal College of Physicians and Surgeons of Glasgow, fellow of the International Society of Nephrology, fellow of the East Central and South African College, and the fellow of the Royal College of Physicians, Edinburgh. He has presented at several international forums. His main interest is in kidney transplantation and diabetic kidney disease. Dr. Baga, you are welcome. Last but certainly not the least is Dr. D.K. Oji, who is the head of internal medicine and an associate professor of preventive cardiology at College of Health Sciences, University of Abuja, Nigeria, and the lead investigator, cardiovascular research unit of the same university. He's also the deputy director, Center for Undergraduate Research and Institute for Advanced Medical Research and Training, both of the University of Abuja, Nigeria. DK also holds an honorary visiting professorship position at Cape Heart Institute, Department of Medicine, University of Cape Town, South Africa. His work spans defining the spectrum of hypertensive heart disease and hypertension pharmacotherapy in the Black population, to establishing a system for hypertension and cardiovascular care in the primary care level in low and middle income countries, to informing national dietary sodium policy. He has been involved in several multi-center studies and led the Creole trial in 10 sites in 6 sub-Saharan African countries, the result of which was presented at the 2019 American College of Cardiology Congress late-breaking clinical session and published simultaneously in the New England Journal of Medicine. He has published more than 130 manuscripts in high-impact journals, including New England Journal of Medicine, Nature Medicine, JAMA, and The Lancet. So we welcome all our speakers. And next, I will want to, let me stop sharing my slides. So we welcome all our eminent speakers. And so the next is for me to lay down some ground rules before we start the session. One is the fact that please, at the Q&A session, you are going to be given opportunities to ask questions, but please, let's endeavor to be brief so that we can give other people, the chance to ask their question. If time permits, we may allow a few of the audience, to may unmute them, and then they could actually verbally ask their questions or comments. For others, of course, you have the chat boxes and Q&A boxes, so you can write your comments and questions in those chat boxes, and we'll look at them, and then we'll ask the appropriate speaker whom the question is directed at, to answer the questions. And at the end of each presentation, we are going to have a summary of take-home points so that at least you can remember some of the things that have been discussed. So without much ado, I will want to call on the first speaker this meeting, Associate Professor Ahmed Reja, to take us on risk stratification, of patients with diabetes during Ramadan. Associate Professor Ahmed Reja, sir, you are welcome.
Okay. Thank you, Professor Ibrahim Gazawa, for your generous and profuse introduction. I would like also to thank the participants who have joined this webinar, and also would like to thank AstraZeneca for giving me this opportunity. So let me share my slide, please. So the topic I'm going to talk about is risk stratification, and the material that I'm going to present is from this latest guideline on diabetes and Ramadan of IDF and Diabetes and Ramadan International Alliance. So I would like to acknowledge the authors, particularly Professor Mohammed Hassanin, who is a chapter lead of this risk stratification, and is also an eminent specialist on diabetes and Ramadan globally, and other authors also I would like to acknowledge.
Sorry, Dr.
So this is the outline of my talk. And
hi, Dr. Ahmed. Sorry, are you projecting from your end?
Sorry?
Are you projecting your screen?
Yes, I'm projecting from my screen.
We can't see your slides as yet.
Okay, so would you like to? Hello?
Hi.
Hello,
Yes.
can you share your slides? We can't see it here.
You can't see it?
Yes. Try again, just as you did the other time.
Okay.
Click on share screen. Yeah.
Can you see it now?
It's coming up. Yeah, we can see it. So can you put it on slide show now? Yeah. Okay.
Yes.
Yes. So we can see it now.
Okay. So this is the material that I have used for my talk, and I would like to acknowledge the contribution of the authors, Professor Mohammed Hassanin and the other authors. So this is the outline of my talk, and I would like to start by giving some introduction. As you all know, Ramadan fasting is one of the 5 pillars of Islam. And fasting is from dawn to dusk, whereby Muslims would abstain from water and food. And depending on the season and geographic location, duration of fast could be anywhere from 12 to 20 hours. Ramadan fasting is associated with changes in eating and sleeping habits that may impact the health of people living with diabetes. This is because Ramadan meals are different from regular meals. People consume larger than usual portions, and the quality of the meals that they consume could be different. As you have been told by our chairman, Islam offers exceptions for those with serious health conditions like diabetes. But despite these exceptions, many Muslims with diabetes choose to fast for religious, cultural, and social reasons. Many healthcare professionals, particularly in Muslim minority countries, do not have adequate knowledge on how to advise and manage patients during Ramadan. And because of this, unsafe fasting during Ramadan could be harmful to our patients. So it's important that healthcare professionals understand how to use various anti-hyperglycemic agents during Ramadan and how to educate them and how to risk stratify them. Because our role is to make sure that our patients living with diabetes do fast safely during Ramadan if they can, or advise them to minimize the risk if they insist on fasting. There are misconceptions around diabetes and Ramadan, and we have to remove these misconceptions in our people living with diabetes. One of these misconceptions is that pricking the skin for monitoring and insulin injections do invalidate Ramadan fasting, but this is not true. Actually, frequent self-monitoring of blood glucose could reduce the frequency and severity of hypoglycemic episodes so that fasting can be performed safely. Therefore, it's important to tell our Muslim people that pricking the skin and insulin injections do not invalidate fasting. And sometimes some healthcare professionals categorically advise against fasting to all patients, Muslims with diabetes. This is not true because based on individualized risk assessment, many Muslims with diabetes may fast safely. And besides the religious, obligation, fasting during Ramadan has a lot of benefits. This gives a sense of fulfillment in participating in all aspects of Ramadan for greater spiritual benefits. And there are also metabolic changes, and these changes in clinical measurements such as blood pressure, BMI, could be beneficial. And sometimes it may also, studies have shown fasting during Ramadan may help with fatty liver disease. Fasting during Ramadan also leads to improvements in self-control and ability to resist temptations. It also gives positive effects such as improving compassion, empathy, and social interactions. It also helps to reduce some harmful habits such as smoking, and also it allows for greater physical and mental well-being. But on the other hand, it could, if not handled properly, it could also have potential adverse effects such as sleep deprivation and disruption of circadian rhythm, glucose excursions, greater feelings of lethargy, short-term feelings of stress, anxiety, irritability, and most of all, some patients may have feelings of fear for diabetes-related complications. Therefore, it is important that we as healthcare professionals provide pre-Ramadan assessment, and preferably it should be done 6 to 8 weeks prior to Ramadan for those intending to fast. And what we need to do is risk stratification, which I'm going to talk in detail, and then review positive and adverse experiences from previous fasting, and then formulate an individualized treatment plan. risk stratification is an important aspect of diabetes and Ramadan. And the new IDF and Diabetes and Ramadan Alliance has come up with risk elements that I'm going to be talking in detail. And we have to know that there are two important risks, particularly hypoglycemia and hyperglycemia with DKA, that could occur in our patients with diabetes. There could also be dehydration leading to increased viscosity and thrombosis. There could be also hypotension leading to stroke, and acute coronary syndrome, heart failure, and arrhythmias could occur. So it's important to keep in mind those risks. And during the pre-Ramadan evaluation, we need to come up with a very structured educational program whereby we risk quantify and then remove misconceptions and educate patients on blood glucose monitoring, exercise, dietary advice, and medication adjustment, and also educate them on when to break their fast. So these are the risk elements for risk score calculation that have been developed by International Diabetes Federation and Diabetes and Ramadan International Alliance under the leadership of Professor Mohammed Hosseini. So this new risk score calculation is available online, or if you have the paper version, this is what it looks like. So there are about 14 elements, risk elements, and each individual risk element is assessed and score is summed up. And the resulting total score will help us to categorize overall risk level. So the type of diabetes, the duration of diabetes, presence or absence of hypoglycemia, level of glycemic control, type of treatment, self-monitoring of blood glucose, the presence or absence of acute complications, macrovascular complications, renal complications should be taken into account, pregnancy, frailty, physical labor, previous Ramadan experience, and fasting hours are taken into consideration. And depending on those risk elements, each risk element is given a score, 0 up to the maximum of 6.5, and then these risks elements will be summed up and used to categorize patients with their risk category. So I will come up with case presentations. These are hypothetical patients. So this is a 48-year-old male accountant, type 2 diabetes for the past 6 years, who is accountant, has regular follow-up at a nearby health center, sticks well to diet and exercise, but does infrequent self-monitoring of blood glucose. He has no associated comorbidities or evidence of chronic complications and never had admissions for acute complications. But last year, he fasted without consulting his physician and was having hypo episodes. Currently, his hemoglobin A1C is 6.8, which is very good. Serum creatinine is normal, and eGFR is 83. He is on glibenclamide 5 milligram twice daily, vildagliptin metformin combination 50 by 1,000 milligram twice daily. So he has come 6 weeks before Ramadan to consult if he could fast, as he is worried about hypos. So what would be your approach is a question. So based on the available information, we have to risk stratify first, whether he is able to fast or not. So we use the new IDF-DAR risk stratification. So based on the available information, his diabetes duration is, he has type 2 diabetes, so he gets a score of 0. Duration is less than 10 years. The score would be 0, and he does not have hypoglycemia. Level of glycemic control is very good. So on this page, he will get only a risk of 1 score because he's on glibenclamide. As you know, glibenclamide, as you will be told by subsequent speakers, is associated with high risk. Therefore, patients who are on glibenclamide will get a score of 1. And he does infrequent self-monitoring of blood glucose, so he gets a score of 1 again. And then last year he had a previous Ramadan experience of hypo, so he gets again a score of 1. The other risk elements he doesn't have, therefore his total score is 3. So if we see at the second patient, this is a 50-year-old lady, housewife, type 2 diabetes with hypertension and dyslipidemia of the last 5 years. She developed acute myocardial infarction 1 year ago. Complaints of left chest pain and dyspnea on mild exertion over the past 10 days. Monitors her sugars regularly, has no hypos, and on physical exam, blood pressure is normal, pulse rate is 92, but irregular BMI is 28. She has bibasilar crackles over the chest and irregular heartbeats, but no other findings. Hemoglobin A1C is 7.2, lipids are normal, ejection fraction is 30, ECG shows inverted T waves in lead 2, 3 AVF. Renal functions are normal, and she is on metformin and dapagliflozin. She is asking you about her possibility to fast during Ramadan. And the question is, what would be your advice? So based on these risk elements, overall, she does not have many risk elements based on this risk categorization. The only thing that is available is her unstable coronary artery disease, which puts her at a very high risk of 6.5. So once we calculate for each patient their risk based on these 14 elements, we will add them up and come up with a score. So if the score is from 0 to 3, it is categorized as a low risk, and the recommendation is that patients can fast. But medications should be modified in some instance. For example, in our patient who is on glibenclamide, it would be good to avoid as much it to a safer sulfur, or if this would be the only sulfonylurea that is available, then you have to reduce the dose and adjust the medications. For our second patient, the risk is 6.5, so that puts her at a very high risk, and she should not fast. But if they have a risk score of 3.5 to 6, that is a moderate risk, they may pass, but appropriate medical evaluation, medication adjustment, strict monitoring is extremely important. If patients do fast against our advice, and it's important that we follow them properly, advise them on frequent monitoring and frequent visits. And one of the important things that we have to advise them is to self-monitor blood glucose. For type 1 diabetes, it is suggested that they monitor at least 5 times per day. For type 2 diabetes on insulin, 2 to 5 times per day. And then type 2 diabetes not requiring insulin, self-monitoring of blood glucose should be individualized depending on the type of therapy, risk of hypoglycemia or hyperglycemia, level of glycemic control, and duration of fasting. Of course, additional testing for periods of symptomatic hyperglycemia or hypoglycemia should also be done. Now, the other important thing we have to educate them is when to break their fast. So all individuals should break their fast if the blood glucose is less than 70 milligram per deciliter or 3.9 millimole per liter. or if the blood glucose is more than 300 milligram per deciliter or 16.6 millimole per liter. If blood sugar is between 70 to 90 or milligram per deciliter or 3.9 to 5 millimole per liter, then they should check within 1 hour and see how they are doing. But if they have any symptoms of hypoglycemia or hyperglycemia or dehydration, or if they develop acute illness with fever or any other illness, they should really break their fast. They should be advised to break their fast. So the take-home message for my talk is that people living with diabetes who wish to fast should have comprehensive evaluation 6 to 8 weeks before the start of Ramadan, and the risk be stratified according to the new IDF-DAR guideline, which is available online, or you can use the paper format. And during this time, general diabetes and Ramadan-focused education should be offered on healthy diet and physical activity, and self-monitoring of blood glucose should be emphasized because this is very, very crucial to avoid both hypoglycemia and hyperglycemia. I know that we have problem in the African region of self-monitoring, but this we should try to emphasize this as much as possible. And then advising on when to break the fast is crucial. Modification of treatment types and regimens as deemed necessary is also important for safe fasting. And if we individualize our approach to our people living with diabetes, our Muslim patients, the majority of them who have uncomplicated diabetes can fast safely. Thank you for your attention.
Thank you very much, Associate Professor Ahmed Reja. So our next speaker now is Dr. Charlotte Ampong, who is going to take us on the adjustment of oral and injectable diabetic medication in Ramadan in the next 20 minutes. By the way, Dr. Ahmed, thank you for keeping to time at exactly 20 minutes.
Thank you.
Yeah. So, Dr. Charlotte, the floor is yours.
Thank you, Prof. Please, are my slides visible?
Okay, Dr. Ahmed, I think you have to stop sharing.
Yes.
Yes. All right. Yes.
Thank you very much for the introduction. And thank you to my audience. I would also like to say thank you to AstraZeneca for granting me this opportunity to talk on this all-important topic. So I will be discussing adjusting oral and injectable diabetic medications in Ramadan. But I will also briefly talk about both the non-pharmacologic and the pharmacologic management of patients during Ramadan. I think my slides are not moving. Okay, and so this is my disclaimer. As I've said earlier, I'll be talking on non-pharmacologic and pharmacologic management of diabetes patients during fasting, and then I'll also dwell on the practical recommendations for medication adjustments. And finally, I'll have a brief slide on safety of SGLT2 inhibitors during Ramadan. So as said earlier, the pre-Ramadan fasting assessment is very critical if a patient is to fast safely. And indeed, it is important because during this period is when the risk stratification occurs, but also the patient gets exposed to the pre-Ramadan educational program, which really dwells on instilling important self-care behaviors that will help the individual to fast safely. So during this period, the patient is taken through dietary management, talk about hydration, appropriate exercise, and self-monitoring of blood glucose, as said by the earlier presenter. But when it comes to dietary management, as we know in diabetes, the nutrition plan must be individualized, and this must take into account the patient's preference, their lifestyle, their age, their medical conditions, and even the ability to monitor. And very importantly, it must be culturally adapted so that the individual finds it easy to accept the management plan. And indeed, based on this, there's a Ramadan nutrition plan that provides a comprehensive guideline on different foods that a person wishing to fast can use in order to fast safely. So which diet is recommended during Ramadan fasting? Indeed, it is still a healthy and balanced diet, and the focus is on complex carbohydrates such as whole grains, seeds, and beans, and as well as a meal that is high in fiber. People willing to fast during Ramadan also need to understand that it's important that they use more healthy fats, as is found in olives, fish, and avocados, and avoid deep frying their foods. In fact, the emphasis during Ramadan fasting is to do more of shallow frying, grilling, and baking. Apart from that, it is important that people fasting during Ramadan understand that for protein, they need to dwell more on using white meats, such as poultry and fish, rather than using red meat. As much as possible, they must avoid processed meats that are high in fats and salt content. And it is important to avoid trans fats that usually will come in fast foods, such as snack food and frozen pizza, margarines, and spreads. The guideline also tells that it's important to reduce the amount of salt a person will take. And in fact, the amount of salt that is recommended is just around 5 grams, which is just around 1 teaspoon of iodized salt per day. People who are fasting must also understand the need to avoid snacking, especially on foods that are high in salt or sugar. And instead of eating those as snacks, they can opt for fruits instead of sweet snacks. But an important concept is the fact that individuals fasting should also, as much as possible, try to cook at home, as this offers them the opportunity to know exactly what goes into their meals and to make the appropriate choices. It is very important for individuals who are fasting to ensure that they are very well hydrated, because a diabetic patient who gets dehydrated is very much at risk of having hyperglycemia and even the thrombosis that was spoken of in the first presentation. Water still remains the best source of hydration, although there are alternatives such as using fruits and vegetables that are high in water content, as well as using dilated and unsweetened juices. While caffeine and tea can be used, it is suggested that these must be used in moderation, as they can lead to dehydration. Individuals who are fasting need to understand the need to avoid sweetened fruit juices and fruit syrups, fizzy drinks, and any other drinks that contain sugar, because these ones can readily raise their blood glucose and cause rapid glucose excursions. For exercise, light and moderate exercise is considered safe during Ramadan fasting. However, if an individual were to take on very strenuous exercise, there's a likelihood of hypoglycemia, and so individuals are advised against doing such exercise during the Ramadan period. It is important for people who are fasting to understand that even the Taraweeh prayer, that is the night prayer, is also considered as part of an individual's exercise regimen, because it really entails a lot of standing and kneeling and bending. And so that really can be part of an individual's exercise. Another important non-pharmacologic measure that needs to be taken seriously is the self-monitoring of blood glucose. And indeed, it is important that if a person wants to fast, they understand that they cannot do so without checking their blood sugars as frequently as possible. And this slide really shows the 7-point glucose profile guide, which directs us to the different times of the day when the individual is expected to check their blood glucose. So for instance, the initial testing is done just before the pre-dawn meal. That is suhoor. And then 2 hours after that meal, the second testing may be done. By midday, it is important to do the third testing, and the fourth testing will come around mid-afternoon. The fifth testing of blood glucose can be done at the preset meal, that is at iftar. And then 2 hours after iftar, individuals are also encouraged to check their blood glucose. Apart from these times, at any point in time when an individual has hypoglycemia or feels that they have symptoms of hypo or hyperglycemia or feels generally unwell, they are encouraged to do self-monitoring of blood glucose. Indeed, as mentioned earlier, the number of times a person may be required to check would depend really on the type of diabetes they have and their risks of going into either hypo or hyperglycemia. And so for some individuals, strictly they would be required to do their 7-point profiles, but others may be able to do 2 or 3 blood glucose checks and do the other ones anytime they have symptoms of hypo or hyperglycemia. So finally, to the pharmacologic and the pharmacologic management of patients during Ramadan. Now, many of our patients would be on oral medications, especially for the type 2 diabetes, but we may also have some of them who would be on both oral medications and insulins. And based on which medications a patient is taking, their risks of hyperglycemia may be more during the Ramadan period. And so it is important that during the pre-Ramadan assessment, all these are taken into account, and where necessary, the adjustments should be made 6 to 8 weeks before the start of Ramadan in order to ensure that our patients are on stable doses and their blood glucose levels are really at the right levels. So for patients who are using metformin just once a day, there needs really to be no dose modification. And what they really have to do is to take that metformin dose at iftar. Iftar is the evening meal. And if a patient is on twice daily metformin dose, then again too, there's no dose modification, but they will have to take 1 dose at iftar and another dose with the pre-dawn meal. Now, if you have a patient who is taking metformin, say 500 milligrams 3 times daily, then what can be done is that because they are not allowed to take any food, water, or drink during the daytime, the morning dose would remain the same with the suhoor, and then the evening dose can be a combination of what they would have taken in the afternoon and the evening. And it's important to remember that usually during the Ramadan period, the suhoor meal is quite lighter than the iftar meal. And so by doubling this dose, it should help control the blood glucose. Now, for people on metformin modified release, they can still take that dose with their iftar meal with no problems. But it's also important to remember that even with all this said, the individual needs to monitor so that if the doses are inadequate, they can be adjusted during the period. Now, if a patient is on a sulfonylurea, and I have to mention that for sulfonylureas, the recommended ones really are the newer generation sulfonylureas, including gliclazide, gliclazide MR, and glimepiride. For all intents and purposes, it is not recommended to remain on glibenclamide while you are fasting because the risk of hypoglycemia is very high, and glibenclamide is really a long-acting drug. And so it's very possible for the individual to go into severe hypoglycemia. So in order to fast safely during the pre-Ramadan assessment, if you have a patient on glibenclamide, then it is important at that time to make a switch to any one of the newer generation sulfonylureas. And if a patient is on once daily SU, such as gliclazide or glimepiride, and that person is very well controlled, then that you can reduce the dose of that drug and give it to the individual at iftar. Now, if they are on twice daily dosing of the SU, then what needs to be done is that they'll take their reduced dose with the iftar, but you also have to make sure that the suhoor dose is reduced because, like I mentioned, usually the suhoor meal is not as heavy as the iftar meal. Now, if you are in a place where the individual has access to repaglinide and or the short-acting insulin secretagogues, usually these are given 3 times a day. Then what you need to do is that you need to dose it across the 2 meals. So just like the metformin where you had 1 dose with suhoor and then the other 2 doses with the iftar, that can also be done here to ensure that the individual's blood glucose are well controlled. For certain medications, usually no dose adjustments are required because they tend to have a lower risk of hypoglycemia. And these include the DPP-4 inhibitors like vidalgliptin, saxagliptin, and then linagliptin. And then we have other medications like tizolidinediones.
Hello, Charlotte.
Hello. Hello, Prof. Okay. Pardon me. Yours. Okay. So for those medications, they do not require a dose adjustment if the individual has been on a steady dose. The GLP-1 receptor agonists and the SGLT2s. But for the SGLT2s, what is important is to remember that the individual needs to take a lot of fluids and it must be also initiated more than between 2 to 4 weeks before the Ramadan. For people who are on insulins, especially where the individual is on pre-mixed insulin, can be analog or regular. What has to be done is that there has to be a shift from the usual pre-Ramadan morning dose to iftar. The reason being that the evening meal is heavier, and so the higher dose of the mixtard must come with the evening meal. And then for the morning meal, we need to take 50% of the pre-Ramadan evening dose instead of the full dose because the morning meal, like I said, is usually lighter than the evening meal. And as much as possible, we encourage them to check their blood glucose 2 to 3 times daily and anytime they have symptoms. So if you have a person who is on multiple daily doses of insulin, such as a basal bolus, and the person is using NPH and regular insulin, then for the NPH, the usual pre-Ramadan morning dose is expected to be taken in the evening. And the dose that otherwise would have gone with the suhoor should be reduced by 50%. Again, for the regular insulin that is usually taken with their meals, the suhoor dose must be reduced by 50%, and that's the pre-Ramadan dose must be reduced by 50%. In the afternoon, we do not give any insulin because that will be equal to breaking the fast. And then such individuals must monitor their blood glucose, at least using the 7-point glucose profile. Now, if you have somebody who is on multiple daily insulin and is using the newer insulins. The newer insulins like the Lantus, Degludec, Ditamer, then for them, they need to do a reduction of about 30 to 40% with their iftar dose. And then for the rapid acting insulins that they take with their meals, they need to reduce their morning insulin dose by about 30 to 50%. Again, they don't have to take any insulin during the daytime, but the dose that will be taken with the iftar needs to be based on their 2-hour post-iftar blood glucose reading. And by using that, they are able to adjust it till they get to a point where they are very well controlled. Sometimes we may have patients who have type 1 diabetes also willing to fast. And indeed, the research shows that they can fast safely if they have the right guidance and the right support, and they are in a facility where they can have access to some of these newer gadgets, such as the continuous subcutaneous insulin infusion and insulin pumps. So for them, the way to go about it is that their basal rate of insulin that they would usually take must be reduced by about 20 to 40% in the last 3 to 4 hours of the fast. And then right after their iftar, we also increase the dose by about 10 to 30%. But their boluses would remain the same as they were taken before the pre-Ramadan. This will be based on the kind of meals they are taking and the established amount of dose they were using before. And so this is just an algorithm explaining all that I had really talked about. So I won't dwell too much on this. But I would like to end really with a short slide on the safety of SGLT2s in people who are fasting. And indeed, it has come as there have been many safety concerns about the use of SGLT2 inhibitors, especially during Ramadan. And from most studies that have been, we know that now, based on the treatment algorithm, we will continue to have many more patients on SGLT2 inhibitors based on maybe the atherosclerotic cardiovascular disease or risk, whether they have heart failure or chronic kidney disease, and even as a means of reducing hypoglycemia. But so far, the problems with, in terms of hypoglycemia and kidney failure, we know that indeed the SGLT2s are protective and they slow down the rate of progression of kidney disease. And then the rate of hypoglycemia is also very low in these SGLT2. Although we do have some genitourinary infections and diabetes ketoacidosis occurring in some patients. So it's important to really choose our patients wisely and take them through the appropriate advice, such as keeping well hydrated and knowing when to stop their SGLT2s when they run into these problems. And so I would like to talk briefly about a study by Shao et al. In 2018, where they actually had patients who were on SGLT2s and those who were not on SGLT2s, and for a period of 3 months. And they looked at ketonemia, hypoglycemia, and then the reduction in the kidney function. At the end of, and they also looked at hypoglycemia. At the end of the trial, it was certain that there was no risk of dehydration with the SGLT2s, even in patients during the Ramadan fasting. And again, those who continued on the SGLT2s did not have a significant decrease in increase in their in the worsening of their kidney function. There was also no increased risks of hypoglycemia during that period. And indeed, there are other studies that have also come along to document these same findings. But at the end of the day, what is clear is that when we are choosing patients to be on SGLT2 inhibitors, we need to keep in mind the risks of dehydration and the fact that during the Ramadan fast, there are long periods when the patient cannot drink water, and advise accordingly that the individual must keep well hydrated during the periods when they are able to.
1 more minute, Dr. Charlotte.
Okay, so to conclude, individuals with diabetes can fast safely during Ramadan, but it's important that there's adherence to the recommended dietary measures, the exercise regimen, and adequate hydration. And we know that appropriate and timely adjustments of anti-diabetic medications can help patients avoid both hypo and hyperglycemia. And that currently, the SGLT2 inhibitors can be safely used during Ramadan fasting. Thank you.
You may now stop sharing so that we can go to the next speaker.
Okay.
So the next speaker is Dr. Hussein Baga from Kenya, who is going to talk to us on on special consideration in patients with diabetic kidney disease. Dr. Hussein? Thank you.
Thank you very much, Dr. Ibrahim, for the kind introduction, and thank you very much to AstraZeneca for giving me this opportunity. I hope my slides are visible.
Yeah.
Okay, so I've been given the task of talking about fasting and diabetic kidney disease, which is quite a complex topic because there's not much evidence in terms of CKD and fasting. There's a lot of evidence in terms of diabetes and fasting from the IDF-DAR Alliance, as has been eloquently presented by the previous two speakers. So I will just go into it. This is the disclaimer slide. My objective is basically to look at the epidemiology of chronic kidney disease, look at the challenges in managing fasting patients who have chronic kidney disease, trying to risk stratify these patients who have got chronic kidney disease and who want to fast. We'll also do a brief case presentation and then, of course, conclude this talk with some take-home messages. So if you look at the epidemiology of chronic kidney disease, the global burden of disease 2015 study suggested that 1.2 million deaths and 19 million disability-adjusted life years, which is quite a bit, and 18 million years of life lost from cardiovascular disease were directly attributable to reduced glomerular filtration rate. And this goes across the CKD stages. As long as your estimated glomerular filtration rate is reducing, your risk of mortality goes up, your risk of disability-adjusted life years goes up, and your risk of mortality from cardiovascular disease goes up as well. This study also suggested that an alarming 32% increase in global mortality from chronic kidney disease was noted between 2005 and 2015. Again, this is a gross underrepresentation because very many countries do not give data or do not collect data for CKD and mortality from chronic kidney disease. Apart from mortality, there's also the aspect of the costs of taking care of patients with chronic kidney disease. And it is a huge expenditure taking care of patients with chronic kidney disease, especially those with advanced chronic kidney disease, including those on dialysis or other forms of renal replacement therapy. High-income countries spend around 2 to 3% of their annual healthcare budgets on the treatment of end-stage kidney disease. Now, in 2010, over 2.6 million people received dialysis worldwide, and the need for dialysis is projected to double by the end of 2030. Now, again, as we're going along, we are realizing now that more and more people are basically requiring dialysis, with the current estimates of around 850 million people living with chronic kidney disease worldwide, and this number is projected to increase. Now, when you look at Muslims and CKD, we have 1.9 billion Muslims worldwide, and majority choose to fast during this month of Ramadan, which is considered to be a very holy month. And this requires abstinence from food and water from dawn till sunset. Now, if you're living in the temperate region, this can be very challenging, especially in the summer months, whereby the fasting period can extend up to 20 hours. Now, when you have diabetes, or when you have patients with advanced chronic kidney disease or patients on dialysis, this can be extremely challenging. And a lot of times, these patients do want to fast, okay, despite the medical professional advising them not to fast. We don't have much data from CKD patients, but we do know that according to the CREED study, patients with type 2 diabetes, almost 95% of the Muslims with type 2 diabetes fasted during the month of Ramadan for at least more than 15 days. And this can be pretty challenging if these patients are considered to be moderate to high risk patients. Now, the concerns that we have with patients with CKD is that they can experience electrolyte imbalances. They can also get dehydrated and can cause worsening of renal function. And this is more challenging in patients with diabetes and CKD, where the risk of hypoglycemia is very high, and as well as the risk of hyperglycemia. I know a lot of us get scared about hypoglycemia, but remember, during the breaking of the fast, a lot of families have very nice foods, which are very high in carbs, very high in sugar content, and people break the fast with those foods. And not surprisingly, the patient's sugars really shoot up as well. Now, there is quite a bit of data and guidelines on diabetes and fasting, but unfortunately, not much data is available for CKD and fasting. So what are the dilemmas that we have as nephrologists or physicians taking care of CKD patients? So first, should a CKD patient fast? 2, which stage of chronic kidney disease is safe for a patient to fast? 3, if a patient is already on renal replacement therapy, either hemodialysis or peritoneal dialysis, how do you manage these patients who want to fast? Patients with diabetes and chronic kidney disease, which drugs are safe to use in these patients who want to fast? And what parameters should we measure? Should we measure the daily weights? Should we measure how do you measure the hydration status? And how frequently should we be monitoring these patients? And when should these patients be advised not to continue fasting? And this presents quite a challenge, because as Muslims, we all want to fast because of the spiritual and the religious benefits that we have for fasting. So unfortunately, we don't have much data for chronic kidney disease. So this is an extrapolation from the IDF-DAR Alliance, whereby they use these categories for to try and extrapolate for CKD patients. And I'm sure we've gone through this slide, whereby these patients were categorized into high risk, very high risk, and moderate or low risk. So for the patients who have diabetes, those who are considered to be moderate or low risk are those patients who have type 2 diabetes, which is very well controlled on lifestyle modification or oral antidiabetic medications, or on basal insulin only. And these patients are allowed to fast. However, they should be under follow-up, and they should be given advice to check the blood glucose regularly. For the high-risk patients, medically it is recommended for them not to fast. However, for those who do intend to fast, then there should be a structured education. They should be advised about the 7-point blood sugar checks. They will need meticulous medical supervision, and they should be advised that they should break their fast immediately in the event of a hypoglycemic episode or very severe hyperglycemia. And these include patients with type 1 diabetes, regardless of the level of control, patient with type 2 diabetes, which is poorly controlled, type 2 diabetes patients who are on mixed insulin regimens, gestational diabetes, those with CKD stage 3, so this is where this extrapolation is coming from, those who have stable macrovascular complications and other comorbid conditions that pose an additional risk factor. Now, those who are very high risk are those who have had severe hypoglycemic events within the past 3 months, or diabetic emergencies like DKA, hyperosmolar hyperglycemic states within the past 3 months, or history of recurrent hypoglycemia, or those patients whose nerves are quite damaged and they have hypoglycemic unawareness, and those with CKD stage 4 or stage 5. So these patients should not fast. Must not fast. So you can see it is a more stronger recommendation. Okay. So We'll go into the case presentation now. So we have Mariam, who is of course, this is not a true patient, a real patient. So she's a 54-year-old female who was diagnosed to have type 2 diabetes and hypertension more than 10 years ago. She's also known to have dyslipidemia. She has been using piroxicam, which is a non-steroidal anti-inflammatory drug for lower back pain, and she takes it over the counter. She's a non-smoker, and she's determined to join the Ramadan fasting this year. Okay, so we have a type 2 diabetic, hypertensive, dyslipidemia, female who is 54 years, who has been using over-the-counter NSAIDs. Okay, and she wants to fast. If you look at it at her estimated GFR using the CKD EPI, it is 58 mils per minute, giving her a CKD stage 3A. Her blood pressure is high. It is at 150 or 95. Her LDL-C is also high at 4.2. Urine albumin creatinine ratio is high at 45 milligrams per millimole. Normal is less than 3. And her proteins show, her urine shows proteins of 2+. Her HbA1c is 7.5%. And she has a BMI of 28 kilograms per meter square, which is overweight. Okay. So we have CKD stage 3A. Blood pressures are high, LDL is high, USCR is high as well, in the range of severely increased albuminuria. The HbA1c is 7.5%, and she is in the overweight category. Her medications include amlodipine, which she takes 5 milligrams once a day, and rosuvastatin, which she takes 10 milligrams once a day. And of course, her regular use of over-the-counter NSAIDs. So what are the concerns from a medical perspective? Maybe I can just give you guys 1 minute. You can just put it up in the chat box. What would be our concerns for this patient, who we tend to see on a regular basis, this kind of a phenotype of a patient? What would be our concerns for her? I mean, of course, we know that her blood pressures are not well controlled. I don't know, Prof, you can read out for us from the chat box if anybody is responding. Yes, so Moses is, yes, sorry, Arvind.
There's low EGFR, renal function.
Excellent. So very good. Low EGFR and hypertension as well. Excellent. What else? We also have uncontrolled hypertension, chronic use of NSAIDs. Very good. There's also the aspect of the albumin being high. Remember, I told you severely increased albuminuria as well. The regular taking of NSAIDs, excellent. Okay, how about the HbA1c of 7.5%? The high LDL, high A1C, excellent. Yes, very good. So I think all of you guys have got it. I mean, these are our medical concerns that we have for this patient. One is that the HbA1c is not a target. She has uncontrolled hypertension. She has impaired kidney function. She has severely increased albuminuria, NSAID abuse, elevated LDL-C. She's overweight. And now she wants to start fasting, isn't it? So these are the things that now we have to tackle one by one and see, is it safe for her to fast? How do we adjust her medications to achieve a HbA1c goal? How do we control her blood pressures? How do we address her impaired kidney function together with the increased albuminuria? What do we do about her NSAID abuse and her elevated LDL-C? And of course, her being overweight, which also adds to her cardiovascular disease risk. Okay? So these are our targets, isn't it? We want to get her eGFR to more than 60 if it is possible. Remember, sometimes it is chronic kidney disease, so sometimes it becomes challenging to get it back to normal, your eGFR. So what you want to do is to introduce medications and lifestyle measures to prevent or slow down the decline of your chronic kidney disease. You want to achieve a blood pressure target of less than 130/80. You want to achieve her LDL-C targets of less than 1.8. You want to reduce the albuminuria to normal albuminuria. or HbA1c to 7% and below, and a BMI to less than 25. Okay, so these are our targets. And sorry, this was rosuvastatin. I made a mistake. It was not atorvastatin. So we would change her to an SGLT2 inhibitor. Remember what the previous speaker very rightfully said is that we need to start these SGLT2 inhibitors 2 to 4 weeks before they start fasting. Please do not start it when they are fasting. Okay, it's very important to remember that. It's important that remember that the guidelines recommend us to start these SGLT2 inhibitors a couple of weeks before the patient start fasting. You can add an ACE inhibitor like lisinopril. Remember, we want to reduce the proteinuria. So your SGLT2 inhibitors will help with the blood sugar control. They're very good in terms of also helping to reduce your albuminuria, as was shown by the various trials. And they also help to reduce your progression of CKD. So lisinopril will help in the blood pressure control as well as helping to reduce your albuminuria. You can increase your amlodipine as well from 5 milligrams to 10 milligrams to help better control your blood pressures, and increase your rosuvastatin from 10 milligrams to 20 milligrams. Okay, when you look at Ramadan fasting and diabetes, this is just one slide that I wanted to bring about. What I wanted to bring about is that fasting can result in excessive glycogenolysis and gluconeogenesis, and at the same time, it can increase ketogenesis in those with type 1 diabetes. So patients with diabetes are at an increased risk of hypoglycemia as well as hyperglycemia as well. We always tend to forget that. And they're also at a high risk of getting diabetic ketoacidosis, especially patients with type 1 diabetes. So it's important to remember that, and that is why the patients with type 1 diabetes are considered to be at a high risk of fasting. Okay? When you look at the dose adjustments for your oral antidiabetic agents, I will not go too much into that because it has been covered very well by the previous speaker. For your alpha-glucosidase inhibitors, there are no changes. For your biguanide metformin, if the patient is taking it once a day, twice daily, there's no changes. If it's once a day, then you basically take it with your iftar meal. If it's twice a day, there's no change. And if it's thrice a day, then you give 2/3 of the dose during the iftar, the sunset meal, and 1/3 of the dose during the pre-dawn meal. And for your dipeptidase 4 inhibitors, there are no changes. Methyltinase as well, there are no changes. Sulfonylureas, again, don't change anything at the iftar meal, but for the pre-dawn meal, if the patients are well controlled, then you can reduce it. Okay. For the newer agents, then you can, like your glycoside MR, you can basically switch them to the sunset meal. For your SGLT2 inhibitors, they should take it together with the iftar. And for thiazolidinedione, there's basically no changes with the taking it at iftar. Okay. For your SGLT2 inhibitors, these are various studies that were done basically during the month of Ramadan, and what is showed was that SGLT2 inhibitors have a very low risk of hypoglycemia. Remember that it only takes care of the sugars that have been excreted or filtered, okay? And no dose adjustments are required during the month of Ramadan, okay? Then there was this very nice study that was done looking at the experience with dapagliflozin in type 2 diabetic patients during the Ramadan fasting. And what they did was that they had 2 arms. One arm was metformin plus sulfonylurea, and the second arm was metformin plus dapagliflozin. And these patients were followed up for 12 weeks, which was excellent because they did the study during the month of Ramadan, and they did follow up after Ramadan to see if any of the effects was still going to be lingering. They excluded patients with an eGFR of less than 60, so there was one caveat. For those patients with recurrent UTI, of course, pregnancy and breastfeeding were excluded. And they also excluded patients who had severe dehydration and were on diuretic therapies as well. It was basically used to determine the number of patients who developed dehydration and the number of hypoglycemic episodes. And the adverse events, what they found was that the patients with metformin and sulfonylurea had a higher incidence of hypoglycemia as compared to the patients on dapagliflozin plus metformin. There was no difference in the proportion of patients with dehydration in both the arms. Okay, the patients with DAPA had a slightly higher incidence of urinary fat infections, although it was not statistically significant as well. Okay, so it is safe to use these drugs. Now, when it comes to fasting and CKD specifically, it is relatively safe for patients with chronic kidney disease stages 1 to 3 to fast, provided they are on very close follow-up. Patients with CKD stages 4 and 5 should be advised not to fast. However, we do know that a lot of our patients refuse to listen to our medical advice, and it is good to assist our patients in those who insist on fasting and that they are on close follow-up. So what we advise them is that patients should break the fast if plasma creatinine increases by 30% above baseline, or symptoms occur due to changes in serum potassium and sodium. If your serum potassium levels tend to go very high, then the patients will start feeling very weak. The same thing happens when your sodium level tends to go low. So once when they start noticing that, of course, they check their sugars if they are diabetic, or they check their serum potassium and sodium levels. Patients should be monitored at least once weekly or twice weekly, and advised to be aware of symptoms such as increase in weight, more than 2 kilograms on the baseline, or they develop edema, swelling of the feet, they develop shortness of breath or dizziness, anorexia or weakness. Once when they do that, they should come to the hospital immediately. And another very important thing is that when breaking the fast, they should avoid, especially for those with advanced CKD, high potassium and phosphorus foods. They should avoid these foods, and also a very high intake of water should be advised if they are allowed to take adequate amounts of water as well. Now, remember that the foods that we use to break our fast dates have a very high content of potassium, so our patients should be advised not to take too many of them. Okay, for those patients who are on dialysis, like hemodialysis, on the day of the hemodialysis, they should not fast. For those patients who are on peritoneal dialysis, they should be advised that they should do the multiple dwells during the night, and then a longer dwell during the day. Okay, and a lot of studies have looked at patients on hemodialysis, and if the patients are closely followed up, it has been shown that there's been no adverse events that they suffer from for those who are on dialysis and who fast. Okay, if you look at the guidelines in terms of stratifying the risk and treating the CKD patients, of course, we do know the conditions that increase the chronic kidney disease risk include those patients who have systemic arterial hypertension, diabetes, cardiovascular disease, family history of chronic kidney disease, previous history of acute kidney injury. Now, very important to note is that even if a patient has had acute kidney injury and it fully recovers, they are still at a very high risk of developing chronic kidney disease. Okay, obesity is another thing that we're seeing becoming very rampant in sub-Saharan Africa and Africa in general. And obesity has been shown to increase your risk of developing chronic kidney disease. Okay, screening for chronic kidney disease, we still use our urine albumin creatinine ratio and our serum creatinine with or without cystatin C, depending on its availability. Okay, now if we identify patients with CKD, we need to treat a specific cause of CKD. Okay, we need to risk stratify our patients. We need to assign them an EGFR category and an albuminuria category. The KDIGO staging of CKD does include albuminuria as A1, A2, and A3. Okay, so we need to do that as well. When your EGFR is less than 60, we need to start looking at renal dosing a lot of our medications. Okay, we need to start patients. Yes, we need to start our patients on medication that will help to slow down the progression of the CKD. We need to avoid NSAIDs. When your EGFR goes to less than 45, then we need to remember to reduce our metformin dose by 50% and then avoid it altogether when the EGFR goes to less than 30. We need to treat hypertension to a target of less than 130 over 80, our HbA1c target to less than 8%. Okay, and we need to look at our the drugs that will basically help in terms of reducing our CKD progression as well as cardiovascular disease risk. And our SGLT2 inhibitors are recommended as our first line in terms of reducing our CKD progression, both in patients with diabetes as well as without diabetes, and they have been used with RAS blockers very safely. So what are our key take-home messages? Patients with stable CKD stage 3 may be able to fast provided that they're monitored before, during, and after the month of fasting. Patients on hemodialysis and peritoneal dialysis may fast provided they adhere to the strict instructions given to them by the nephrologist. SGLT2 inhibitors are safe and tolerable during fasting, but please do not start them during the month of fasting. Start them a few weeks before fasting. Okay. And if not at HbA1c target, continue metformin unless contraindicated, and add an SGLT2 inhibitor or a GLP-1 receptor agonist with proven cardiovascular benefit. And if any further intensification is required for patients with diabetic kidney disease, you can choose an additional agent demonstrating cardiovascular safety. So I'll end the talk there and happy to take any questions. Thank you very much.
Thank you very much, Dr. Hussein. The next presenter is Dr. DK Oji, who is going to take us on special considerations in patients with Dr. DK, you are welcome.
All right. Thank you very much, Professor Gezawa, for chairing this meeting so very well.
Thank you.
Yeah. I hope you are seeing my screen.
Yes.
Okay, good. And I also want to acknowledge fellow panelists for the beautiful presentation and everyone that has joined. And also AstraZeneca for the opportunity to give this talk. So I'm going to be concentrating on the diabetic patient with cardiovascular disease for obvious reasons. These are my disclosures and also my disclaimer. I will follow this outline looking at diabetic patient or diabetes being a major driver for cardiovascular disease. And I go straight to the case study and I talk a bit about heart failure with preserved ejection fraction, which can be highly driven by diabetes. And I talk about Ramadan fast in a diabetic patient with established cardiovascular disease. Then I will conclude. Now, it is one of the leading risk factors that drives cardiovascular disease all over the world. Of course, hypertension is cigarette smoking. Then after that is diabetes. And you can also see some other risk factors like physical inactivity down to indoor smoke or what we call biomasses. From the Framingham study, it is well established that heart disease occurs in people with diabetes 2 times as often as it will in people that don't have diabetes or who are normoglycemic. And cardiovascular disease complications occur at an earlier age and often result in premature death. So in diabetic patients, one of the major causes of premature death is, of course, cardiovascular disease. And diabetic patients are 2 to 4 times more likely to suffer cerebral had a stroke. They are 2 to 4 times more likely to have a reoccurrence compared to people that are not diabetic. This is from the Framingham Heart Study. If you look at risk factors that drive cardiovascular disease, it is said that high sugar or diabetes accounts for that in about 8 to 9%. While the leading, of course, risk factor is hypertension. Diabetes is said to be equivalent to cardiovascular disease. Why? Because when the glycated hemoglobin increases, then from cardiovascular disease and also ischemic heart disease also increases. You can see that at above 7%, you can see that the risk of death from cardiovascular disease and ischemic heart disease is higher compared to lower figures. So I go straight to this 65-year-old Muslim man who was diagnosed to be hypertensive 15 years ago, and he presented edema, he has easy fatigability, and he has difficulty in breathing when he maybe takes a step or does some exercise. He complains of paroxysmal, not a dry cough. Now, There is associated type 2 diabetes of about 5 years, and patient also has dyslipidemia. On the family and on the social side, it's not a smoker. However, he does not exercise. He has bad diet habits, so maybe it takes a lot of junk food, and is a truck driver. So on physical examination, the pulse is 88 beats per minute, is moderate, volume is regular. The blood pressure is elevated at 156/94 millimeters of mercury. He has a first, but as you can see, there is no tachycardia, just less than 90 there. Then he has bibasal fine crepitations. The ECG showed T-wave inversion in list V1 to V6. That actually talks about widespread ischemia. Then when the transthoracic echocardiography was performed, he has a mildly dilated LA of about 4.2 centimeters. Normal should be less than 4. And then he has a normal left ventricular size, which is quite important because if I'm seeing a might go to some other etiological factors driving the hypertension. And what we call the E over E prime, which is a way of measuring filling function, is elevated. 13 is abnormal. It's supposed to be less than 8. Then left ventricular ejection fraction is preserved. That is at 52%. 50 and above is normal. So if clinically I'm seeing this patient, I'm going to be looking at a patient that has heart failure with preserved ejection fraction. Because of the symptoms this patient has presented with. And when I did my echocardiography, the systolic function is normal, but he has an abnormal diastolic function. So the HbA1c is poor. There you can see poorly controlled at 8.2. We've mentioned before the blood pressure 156/94. The LDL cholesterol is elevated. We want a value less than 1.8 for this patient. Now you can see the eGFR of the patient. That is 79 above 60, and then the BMI of the patient is high at 25 kg per meter square. Of course, we want it less than 25 kg per meter square. We saw this in previous presentations. So what are the problems you can identify in this patient? One is a long-standing hypertension. Two is diabetes of function occurring with diabetes. Of course, you know that the effect on the cardiovascular continuum is multiplied. And then we should expect more atherosclerosis. And so I'm not surprised that this patient has widespread T-wave inversion from V1 to V6. This patient also has dyslipidemia. He has a family history of diabetes, and then a works driver. This is more sedentary and also a stress-free job. Then patient has heart failure with preserved ejection fraction. I established this patient is 52%, above 50 cutoff mark. In terms of target, we cannot overemphasize this. The glycated hemoglobin should be less than 7%. For a diabetic patient, I will aim at a blood pressure that is of mercury. Then for the lipid LDL, low density lipoprotein cholesterol, I should be aiming at less than 1.8 millimole. And for eGFR, we found out that this eGFR is preserved. And we've said this before. This patient is obviously overweight with a BMI of 29. So this patient is on metformin. So maybe the question I will ask, do you think metformin is sufficient for this patient? And so yes or no. Now, if metformin is not sufficient for this patient, which other agent which other agent will you add to the medication of this patient? Can I give us just like 1 minute to just put something on the chat. So which other agent? Is anyone putting something there? People, okay. Yes,
Not
I've
yet.
seen one. I've seen SGLT2 as source of an statin ACE inhibitor. That is true, but we are concentrating on diabetes now. Metformin is not sufficient as SGLT2. Great. Glyphosate. That is great. Okay, so so we get to that later. So should we optimize or switch treatment for HbA1c control? So do you want to increase the metformin the patient is taking? Is blood pressure improvement required? Of course, it's required, very much required. We have seen this before. So for this type of patient, I'm going to be interested in giving metabolically neutral agents. This is a long-acting calcium channel blocker, and I'm going to use a RAS blocker. Either I use an ACE inhibitor or an angiotensin receptor blocker. Of course, for this type of patient with very high risk, I'm going to go for moderate to intense 40 milligrams of rosuvastatin, 20 to 40 milligrams of rosuvastatin, and 40 to 80 milligrams of atorvastatin in this type of patient. Now, before we looked at another agent to add, let me take us through this. Let us remember that older glucose-lowering agents have not definitely shown positive effects on major cardiovascular events. That is well established from the acarbose versus placebo study, from the glycoside, agent studies. They have not been any benefit of the older glucose-lowering events. Most of them have been neutral, and few of them have actual events. And what actually broke, the back of the camel was the Avandia story. I'm sure we remember by Pfizer, and it was found out that rosiglitazone was associated with risk of myocardial infarction and death. And because of this, it was withdrawn from the market. And from that time, FDA made a rule to be marketed, to be said to be safe for use. It must undergo cardiovascular safety profile. It must be tried. We must know the cardiovascular safety of such medication. And for DPP-4 inhibitors, they were largely cardiovascular neutral. That DPP-4 inhibitors. So for this patient, am I going to add a DPP-4 inhibitor? No, I won't go that way because they were not found to protect the cardiovascular system. And so suggested I'm going to add an SGLT2 inhibitor like dapagliflozin to the management of this patient. So, because when this patient was profiled, he has heart failure with preserved ejection fraction. And now in the management of heart failure, it is only the SGLT2 inhibitors that can be used throughout the spectrum of heart failure. For heart failure, we reduce ejection fraction, they have a place. For heart failure with preserved ejection fraction, they have a place. For heart failure that have mid-range ejection fraction, they have a place. And also for heart failure with improved ejection fraction, they have a place. How do we come about this classification? Heart failure with reduced ejection fraction simply means that the patient has a left ventricular systolic function, ejection fraction of less than 40. And for those that have ejection fraction of 40 to about 49, we call them heart failure with mid-range ejection fraction. And by the time a patient has a heart failure, but the ejection fraction is 50, percent and above, then that patient has a heart failure with preserved ejection fraction. So the SGLT2 inhibitors in the guideline have been recommended for the management of heart failure with preserved ejection fraction. So for this patient, apart from metformin, I'm not going to increase the dose of metformin, but I'm going to add an SGLT2 inhibitor like dapagliflozin. So, and this talks about the ESC guideline when it comes to management of diabetic patient who is at high cardiovascular risk. And I want you to look at the third line. It said SGLT2 inhibitor like canagliflozin, dapagliflozin, epagliflozin, etagliflozin, and sotagliflozin are recommended in patients in diabetes at high risk of cardiovascular disease or with cardiovascular disease in order to prevent heart failure hospitalization. So even for patients that are at high risk, they are profiled and the risk is high, SGLT2 inhibitors are highly recommended. So risk stratification for fasting during the Ramadan period for people living with diabetes. I know Professor Raja did so much with this, but I want us to just look at it in relationship to this patient. Of course, factors for risk stratification include types of diabetes, with type 1 diabetic carrying higher risk compared to type 2 diabetic, patient medication, individual hypoglycemic risk of patients that have repeated hypoglycemic risk, they are more at risk. Their risk will increase. Presence of complications or comorbidity. This interests me so much. So if a patient has an established cardiovascular disease, that increases the risk so much. And for me also, I want to look at the patient. Is the patient stable? The cardiovascular disease stable or not stable? For this patient is unstable because he has dyspnea on exertion. This patient has bilateral pedal swelling. This patient has paroxysmal nocturnal dyspnea. The blood pressure of this patient is not controlled, and the pulse is just borderline, just 2, below 90 beats per minute mark. Then we also consider individual social work circumstances of this patient. This patient is a truck driver, has a lot of, apart from the sedentary life, it takes a lot of stress on the patient. Previous speakers have dealt much on this, and also this, and one of the points that actually interests me is multi-vessel disease. For this patient, I feel it will have a more the left ventricular size is still not why the ejection fraction is preserved, but this patient has widespread T-wave infarction, must have quite some atherosclerosis. And then this patient has symptoms of heart failure. And we concluded with a heart failure with preserved ejection fraction. This was also shown before. So for risk stratification of people, do the risk score. Of course, 0 to 3 is low risk. 3.5 to 6 moderate risk, it's high risk, and you can see what before. And when it is 6 and above, fasting is probably unsafe. The physician to advise the patient not to do so and to document. But then it is important to document that you have advised the patient. Risk stratification, I just pick some of them. Type of diabetes, type 2, glycemic control, and then you can see that for multi-vessel disease morbidities, that is about 6.5. For total, it's about 9. If I'm seeing this patient, it will be safe for me to say that this patient not to fast, and I want to document it. And if the patient decides to evaluated more frequently, and he has to be properly educated, as we saw before. So to summarize, the leading risk factors for cardiovascular disease globally have matched as a choice agent for diabetic patient with established cardiovascular with high risk. Now, decision to cancel a diabetic patient to fast or number of factors. I'm talking about in terms of cardiovascular disease, and that is especially of the established cardiovascular disease. Thank you very much.
Thank you very much, Dr. DK. Patients with diabetes with CVD and fasting. So although we are a bit ahead of, we wanted to complete this webinar by 7, but it's like we're ahead of schedule. But all the same, at this junction, I want to say that we have 20 minutes for questions. And so as I mentioned earlier on, that you can put your questions on the Q&A box. And I think we have questions already, which I will go through one by one and then direct to the specialist who dwell on the particular topic that the question is talking about. So okay, Dr. Ahmed Reja, I'll start with you. Says, is there any development in updating the risk stratification guidelines, which was first published in 2016?
Yeah, okay. Thank you, Prof, and thank you for the individual who asked this question. As you know, there have been several guidelines that have been coming out on diabetes and Ramadan, but the latest one, which I used for my presentation, came out in 2021. This was a collaborative work between International Diabetes Federation and Diabetes and Ramadan Alliance, which is spearheaded by Professor Mohammed Hosseini. So the previous guideline of 2016 has been and made because the previous guideline divided individuals risk into a 4-tier risk categorization. Very high risk, moderate risk, and low risk. But this created confusion, and therefore there was a consensus that the risk categorization should be a 3-tier categorization into low risk if the score, the total score, is between 0 to 3, which in which case patients can fast, and moderate risk is 3 to 6, and above 6 is high risk. 3.5 to 6 is moderate risk, more than 6 is a high risk. So it is a 3-tier risk. So this is a very good guideline, which I encourage everyone to look into. And the risk categorization, there is an app on the web. You can use it. If you go to the DAR Alliance website, you can find it, and you can print it and then use also the paper version. So that's right. There has been an improvement in the previous guideline.
Okay. Well, thank you very much, Dr. Ahmed. The next question from an anonymous attendee is, I think it should be directed to Dr. Charlotte. It says, what is the fair complication of starting SGLT2 inhibitors during fasting?
Okay, so thank you for that question. I think the main fear is that of dehydration. If you look at how the SGLT2s work, they block their reabsorption of glucose, and so you not just glucose, but you're of sodium as well. And so there's a lot of osmotic diuresis, and the patient tends to pass a lot of urine when they are on the SGLT2s. Now, given that during Ramadan, an individual cannot take in either food or water from the start of the fast till it ends, then if you're going to put a patient on an SGLT2 during a period like that, the individual is really going to be at high risk, because you wouldn't know how much fluid even the patient has to take to make sure during the period when they can drink and eat, to make sure that they stay well hydrated during the time of the fast. So I think that's the main problem with starting during Ramadan. Indeed, if you are able to place these people on the SGLT2s at a time when they are not fasting, then you can better advise them on how much fluid to take to ensure that they do not become dehydrated. Thank you.
Right. Thank you very much, Dr. Shah. I think before you go, another one that I think you may want to answer from Rahina to Ibrahim. She said, suhoor, that's the pre-dawn meal. For most people, is the time to eat heavy. Iftar, on the other hand, is when people take a lot of fluids and fruits. Shouldn't we take that into consideration?
Okay. Okay, so I think this is a bit new, because often iftar is supposed to be the heavier of the two meals. Definitely. But I believe that maybe based on where you are, it may be the opposite. But whatever the case is, in deciding how to give the medication, it's important to work with the patient so that we make sure that whatever we are giving them is commensurate with the meals. But ideally, there's the iftar that is the heavier meal, while the suhoor is supposed to be a lighter one, more vegetables and fruits.
Okay, and another one related to dehydration from one Enoch Ayornu. He said, how does a patient stay well hydrated if during fasting period water intake is not allowed?
Okay, thank you. So I did mention in my slides that it's important that they stay well hydrated, and sometimes they may need to take as much as 8 to 10 cups, translating to about 2 to 2.5 liters or even more. But they do that from iftar to suhoor. So that is why it's so important to know how much water an individual needs to stay very well hydrated on the medications they are taking. Because once the fast starts, you are not allowed to take water or food. But aside from the water, I also mentioned that even foods that are high in water, and you can take in some teas, but you need to avoid things like caffeine that may also lead to a bit of dehydration. So they do that between iftar and suhoor. That's in the evening.
All right. Thank you very much, Dr. Charlotte. I think this next question is directed at Dr. Baga. He said thanks from one Gordon Yusa. He has two. You should comment on CKD and statin dose. And then the second question is, do you observe reactive hypoglycemia?
Okay, thank you very much. Yeah, so when it comes to advanced CKD, especially CKD 4 and 5, then we need to halve the statin dose. That is what is recommended, and it's very important, because if you give the full dose, especially in CKD stage 4 and 5, then you're at a higher risk of developing the side effects of myopathy. Now, have I observed reactive hypoglycemia? Now, it depends. We have seen patients who, when they take their anti-diabetic medications, especially the insulins, and they've not done the carb count, especially with CKD, because the risk of hypoglycemia is much higher. Remember that the kidney is essential in metabolizing your endogenous as well as exogenous insulin. And it is recommended that in advanced CKD stage 4 and 5, you need to halve your dose of insulin. That is, reduce it by 50%. And a lot of patients are not advised on that. Then you can get a reactive hypoglycemia after eating, like 3 to 4 hours down the line. Of course, if you have had bariatric surgery as well, this can predispose you to getting reactive hypoglycemia. If you take heavy alcohol, it can also predispose you to reactive hypoglycemia. Specifically for our diabetic and CKD patients, if they have symptoms of reactive hypoglycemia, then it's important to adjust the dose of your medications, either reduce the dose or switch to another one that will not cause a hypoglycemia. Thank you.
All right, thank you very much. This next question also from an anonymous attendee. I think probably Dr. Ahmad will want to comment on that. He said, if a patient comes with diabetic emergency rather than hypoglycemia and still want to continue with fasting after discharge,
Thank you
what should I do?
for the question. This is a very difficult situation because patients should be evaluated, educated pre-Ramadan. You know, they have to be educated pre-Ramadan, evaluated, risk stratified, and once they are risk categorized, then you can give them recommendations. But if anybody has come with any emergency other than hypoglycemia, that means their glycemic control will be disrupted, and they may have other comorbidities, and it will be really difficult to recommend them to continue fasting. But if they insist, then you have to work with the patient. You have to they have to make informed decision. But if they insist, despite your advice not to fast, then what you can do is advise them to have frequent monitoring and frequent visits, and report immediately whenever they have an emergency. But this sort of patients should not be really allowed because they are past a medical emergency. It could be DKA, it could be any other emergency. So, but if they insist on fasting, then you have to monitor them very closely, do blood sugars frequently, see them every week at least, and then give them access for consultation in case they have any issues. But this is really a very difficult situation.
Thank you very much, Dr. Ahmed. Two other speakers also, two other members of the audience also asked similar questions. So you have answered all of them. Now, the next question is directed at Dr. Hussein from a colleague, Professor Aisha Nalado. She said, can you comment on the use of SGLT2 inhibitors during fasting in kidney transplant?
Okay, that's a very good question. And unfortunately, we don't have data for SGLT2 inhibitors during fasting in a kidney transplant patient. However, we do know that patients who are post-kidney transplant and who have fasted, there have been small studies that have come out from Iran and Saudi Arabia that show that it is safe for these patients to continue fasting post the kidney transplant as long as they're on very close follow-up. And what they were looking at as the endpoint was the changes in the serum creatinine and the estimated glomerular filtration rates. They found that there was no difference between those who are post-kidney transplant and those who are not transplanted. However, they did not comment about the use of SGLT2 inhibitors. However, what we can do is that we can always look at our patients individually. If a patient has very stable creatinine post the kidney transplant, has been using the SGLT2 inhibitors, has been quite stable, is compliant to following instructions and taking medications, and is not getting episodes of dehydration pre-fasting, then we can allow them to use SGLT2 inhibitors, but of course, keeping in mind that they have to hydrate themselves well after breaking their fast and also before starting their fast as well. And they need to have very close follow-up for their monitoring the kidney functions as well, so that that Should they encounter any problems, then we can always withhold it during the month of fasting, and then of course subsequently restart it again.
From Johannes and the show. The question is, how would we advise in taking precautions while engaging in vigorous exercise from evening through the night? I don't know who would take this, Dr. Ahmed or Dr. Ahmed, you want to comment on this?
Yeah. Okay. Yeah, I can. Thank you so much again for the question. Now, you know, when we advise about exercise, the usual physical activity can be continued. And, you know, there is tarawih, which occurs after, you know, breaking the fasting after iftar. For 2 or 3 hours, Muslims will be praying, bowing, and so on. So that is also should be taken into consideration. But if they want to do vigorous exercise, what is important is that they have to check their blood sugars level frequently, pre-exercise, during exercise, and post-exercise. And then they should be well hydrated, they should be well educated on recognizing hypos, and then on taking appropriate actions. But the advice should be to be engaged in moderate exercise rather than vigorous exercise, and get well hydrated. What is the risk of vigorous exercise is hypoglycemia, and also they can have hyperglycemia, even DKA in type 1 diabetic patients if they are not well controlled. So rather than vigorous exercise, low to moderate intensity exercise is what is advised. And the tarawih, the prayers, the long hour prayers are also important part of the exercise program. So that would also help them in controlling their blood sugar levels. That's what I can say.
Thank you very much.
Professor Gezewa, can I come in here?
Yes,
on the point of cardiovascular status. So we don't really, just like previous speaker said, we don't, Professor Reja, we don't really advise vigorous exercise. I mean, apart from issues of hypoglycemia, the other issue is most times the coronaries might not be that clean. And if you are involving yourself in vigorous exercise, the heart will require more blood flow. The coronaries might not be able to cope. You might rupture a plaque. There might be displacement of a plaque, and then an event can occur. So as much as possible, we should avoid that, except we are very sure of what the status of the coronaries are.
Okay, thank you very much, Dr. Adike, for that addition. Well, here, Monira, you whether a patient who cannot afford glucometer for frequent measure, how can we advise such a patient in terms of the SMBG that is very crucial during fasting? I don't know who will comment on this. Dr. Charlotte, you want to say something here?
Yes, Prof.
Yeah.
So self-monitoring of blood glucose is really a critical aspect of the management of a patient who is fasting during Ramadan, for the simple reason that it will help pick up hypoglycemia and hyperglycemia and show the individual even when to stop fasting or when to, as well as when they can continue. So without a glucose meter, unless you can have access to one readily, otherwise, as I mentioned in the slides, a person may be required to check maybe 7 times a day, but at least about 2 to 3 times in a day, and anytime they have symptoms as well. So it really is important to have a glucose meter, but if you still want to fast without one, then it's important that you have access to one, maybe from a nearby clinic or a pharmacy elsewhere. Yes.
Well, yes, thank you very much. I think this is a major issue with most of our patients, especially from sub-Saharan Africa. I remember at the first physical meeting of DA Africa held in Kenya in December, we actually looked at data, a survey data from 2022 Ramadan. Pass without monitoring, but I think that's not something we should encourage. As you said, we should try to see how we can, advise them, even if it means going to, nearby laboratories to check their blood sugars, but particularly also to definitely check whenever they have symptoms of either hypo or hyperglycemia. Thank you very much. So the next question is, this is asking a question that I don't know, maybe all of us will put heads together to answer. I said, if a diabetic patient came in at emergency with moderate dehydration and I prescribe IV fluids, will it disrupt the fast? So he further gives detail of that. Does intravenous medication or IV glucose prohibited in fasting?
Yeah, I can answer that.
Okay, yeah.
Okay, yeah. When we say when I talked about the misconceptions, I talked about skin pricking for self-monitoring and insulin injections. Okay, so this wouldn't invalidate Ramadan fasting, but whenever you give fluids, you are giving some nutrients. Okay, so be it normal saline, be it DW, whatever, you are giving nutrients. So this would really invalidate the fast. So they have to break the fast anyway. These patients, if they have come with an emergency situation, whatever, any emergency situation, they have to break the fast.
Yes,
exactly. The fact that you are also giving them IV fluids will also disrupt the fasting, because you are giving them some nutritional values. So that will disrupt the fast. So that's what I can say.
Yes, agreed, Dr. Ahmed. I mean, a patient during Ramadan coming to the emergency room with moderate dehydration, that on its own, invalidates the fasting because it's an emergency, so he has to be treated. Thank you very much for that. Muchunguzi. She said, how can a lactating woman with controlled type 1 DM but has no other comorbidities be advised on fasting? Again, Dr. Ahmed, I think.
Sorry? Well, yeah, I mean.
Talking about lactating woman with type 1 diabetes, how can we advise her in terms of fasting?
Yeah, if she has well-controlled type 1 diabetes.
Yes, she has well-controlled, yes.
So, yeah, and no other comorbidities, then she has to be evaluated. She has to be taken and her risk stratified. And then she can be advised to fast based on her risk elements, whatever she has. So particularly if she has opportunities for self-monitoring, and if she can be well educated, then she can be allowed to fast. So this has to be individualized.
Yeah. Thank you very much, Ahmed, for that.
Sorry, Dr. Geza. Yeah, Professor Geza. Was a so
yes,
I know Dr. Sain Baga, you spoke to that also. But just to say that for patients that we have that have CKD, depending on stage, especially if you are dealing with stages 4 to 5, we prefer use atorvastatin and not rosuvastatin because of the route of excretion. If you use rosuvastatin, likely the renal function of that patient will worsen. So for those type of patients suspicious of a CKD, especially stages 4 and 5, atorvastatin is better for them. I just feel I should mention that. Thank you.
Yes, thank you very much, Dr. DK. In fact, something came to my mind when we talk about statins. We normally don't consider, although we do that sometimes, but the diabetes can have other comorbidities. So it's really important not to concentrate only on the anti-diabetic agents, but other medications for other comorbidities that the patients are on. In fact, even the use of statin is not encouraged, according to some experts, at the beginning of Ramadan. If the patient has not been on statins before Ramadan, it is not advisable to start immediately at the onset of Ramadan, because some have argued that, the fatigue and the myopathy, that comes with the use of statins may actually somehow affect, the individual while fasting during Ramadan. So they advocate that the statins should have been used for like 2 to 4 weeks. Yeah.
Yes.
Chat. So, but I don't know if any of the panelists has additional comments to make regarding overall, what we have.
To make the last comment is that we as healthcare professionals should be very proactive in asking patients their plan to fast or not to fast. And we should not really wait or just keep quiet. So we have to ask our patients whether they would like to fast, and then bring them over at least 2 months before Ramadan, so that we evaluate them comprehensively and then advise them in an appropriate manner. So if we do that, I think many Muslims could fast safely. Otherwise, if we are not proactive, then our patients may be falling into trouble.
Okay, thank you very much, our eminent speakers and the panelists. I think it's been an interesting meeting. I'm sure the audience will agree with me that it was an educative and very interactive webinar. And at this point, I think our healthcare professionals at least should be equipped, to be able to advise and manage their patients with diabetes during Ramadan. So at this juncture, I want to hand over to AstraZeneca, to give they have a closing remark as well as a survey that they want to actually conduct, to ask the audience about their experience. So it's Mr.
Okay, thank you so much, Pro. Good evening, all. I'm Dr. Julia Wellens-Mensah, Medical Science Liaison for CVRM with AstraZeneca. I would like to extend our sincere gratitude to you all for taking time out of your schedule to join us for this meeting. A special thanks goes to our august faculty who delivered excellently on the topics, as well as our chairman, Prof, for his for coordinating the session. I hope and trust that this session has been impactful and that we've learned a lot that can help shape our clinical practice. As a follow-up to this session, we do have another meeting on the 8th of March, which also dives into diabetes and Ramadan, as well as some of the comorbidities, to help refresh our memory ahead of the Ramadan period on how to manage our patients during the fasting period. So from AstraZeneca, we'd like to say a big thank you and do have a good evening.
Thank you. Thank you very much. To everyone for a very...
Thank you. Thank you.
Thank you.
Bye.
Thank you, everyone.
All the best.
Thank you, everyone.
Teachers.